So sulfonamides, they were the first used antimicrobial agents. So Prontosil is an example. Pronto means one, right? First used. They were the first effective antimicrobial agents used in the treatment of bacterial infections in humans. They're the derivatives of sulfanilamide. Okay, what is sulfanilamide? Para-amino benzene sulfonamide. So para-amino benzene sulfonamide. Okay, para-amino benzene sulfonamide. So, what is the classification? Remember it like this: dias-methoxocale boxing. So, acetate. Dias-methoxocale boxing. A for acetate. Acetate is timid. So, Salazar. So, dias. Sulfa-diazine. Methoxale. Methoxazole. Sulfa-methoxazole. Short-acting, intermediate-acting, and long-acting. Boxing or doxin. So, sulfa-methodoxin. Next, sulfadoxin. Next, local acting agents, you have acetamide, so acetamide, sulfacetamide, and sulfadiazine, and others salicine, so sulfasalicine. Okay. So dias, sulfadiazine, sulfamethoxazole, sulfdoxin, sulfacetamide, sulfasalicine. So mechanism of action, basically they competitively inhibit the folate synthase enzyme because folic acid metabolism is needed for bacterial growth and replication. So they competitively inhibit the folate synthase enzyme and prevent the formation of folic acid, producing bacteriostatic effects. So sulfonamides prevent this enzyme, so DHF and THF are not formed. Mammalian cells don't synthesize folic acid and only get it from the diet. So that is why they are not affected by sulfonamides, which alter folic acid synthesis. So bacterial resistance to sulfonamides, how have bacteria formed resistance to it? So binding site has been altered, so affinity for the drug decreases, efflux of the drug from the bacteria, and development of different biochemical pathways for folic acid synthesis. Pharmacokinetics, they're highly bound to plasma proteins, acetylated in the liver, which causes the toxic waste to be generated. Okay, it is excreted in both changed and unchanged form. What are the adverse effects? So remember sulfonamide, sulfa drugs, right? So G6PD, if you use sulfa drugs, you have hemolytic anemia that occurs. Then again, jaundice, especially in young children, it can cross BBB, kernicterus. Next, because they're acids, right? Sulfa acids. So the acetylated products are poorly soluble in acidic urine, so they can crystallize, and from crystalluria, hematuria, or obstruction to the urinary tract, they can be treated by alkalizing the urine. Okay, it also causes hypersensitivity reactions. So Stevens-Johnson syndrome is the most severe type of hypersensitivity. What are the drug interactions? So sulfa drugs interact with the sulfonylureas, so oral hypoglycemic agents. They can also interact with methotrexate and oral anticoagulants. RBC already we discussed, right? G6PD, so platelets, anticoagulants. Next, therapeutic uses. So you can use sulfadoxine and pyrimethamine for Plasmodium falciparum. Next, toxoplasmosis treatment. Next, silver sulfodiazine can be used for preventing burn wound topically. Infection of burn wound. And then sodium salts of sulfacetamide, timid. Okay, timid, so you can use it on the eye as eye ointment. So because of high aqueous solubility, neutral pH, non-irritant nature of drug, good penetrability on topical administration, and low cost. Oxysol is a WHO approved fixed dose combination of sulfamethoxazole, so methoxocale, and trimethoprim. Okay, metho and methoxocale on the stage, right? So sulfa, so prime. Okay, trimethoprim. Sulfamethoxazole and trimethoprim in the ratio 5:1. There is synergism at 20:1 ratio. Okay, so how do they act? Basically, they produce sequential blockade. So sulfamethoxazole inhibits this step, folate synthase, and trimethoprim inhibits this step, dihydrofolate reductase. Synthase and reductase are sequentially inhibited. So that is why there is a supra-additive effect that is produced. Okay, so basically individually both are bacteriostatic. Okay, but combined they are bactericidal. Okay, and combination reduces the risk of resistance occurrence. Okay, they have similar half-lives. Okay, all this is said. Next, pharmacokinetics, all are given orally, extensive metabolism in the liver, and excreted mainly in the urine. Okay, adverse effects. Cotrimoxazole is well tolerated in most patients. Most of adverse reactions are because of the sulfa component, so there are skin rashes and severely, sometimes rare instances, Stevens-Johnson syndrome. GA symptoms are nausea, vomiting, and glossitis. Megaloblastic anemia may occur rarely because of folate deficiency. Now moving on to the preparations. So remember, you have 5:1 ratio of sulf-methoxazole to trimethoprim. Tri is 3, sulf-methoxazole name is big, so 5. Okay, so remember 20, 40, 60, sorry, 20, 2s are 40, 42s are 80, 82s are 160, okay, mg. So into 5 times is this value. So how do you give it? So 20 is pediatric, 40 is oral, 80 is IV, and 160 is IM, okay. Therapeutic uses. So in cotrimoxazole X is for excretory tract. So urinary tract, so UTI. It is useful for chronic and recurrent UTIs, especially in women, and long-term prophylaxis of recurrent UTI. And bacterial diarrheas, it is used mainly in Shigella, E. coli, and Salmonella species, gram-negative bacilli. Okay. Next, you can use it in respiratory tract infections such as bronchitis, and again nocardiosis, nocardias. Okay, so nocardiosis, you can use it. So quinolones and fluoroquinolones. The first quinolone, which is nalidixic acid, quinonalidixic acid, so queen-nalidixic acid, is a urinary antiseptic. Okay, so it is effective against gram-negative bacteria such as all that we'll be discussing. It basically inhibits DNA gyrase enzyme and interferes with the replication of bacterial DNA, and it is used in the treatment of uncomplicated UTI due to gram-negative bacteria. Okay, so first fluoroquinolones are fluorinated synthetic analogs of nalidixic acid. So first generation ones are norcipro, so norfloxacin, ciprofloxacin. Second generation levo, okay, ofloxacin, levofloxacin, okay, the second generation drugs. Mechanism of action. So how do fluoroquinolones act? DNA gyrase, they inhibit that by causing inhibition of topoisomerase 2 in gram negative and inhibiting topoisomerase 4 in gram positive. They nick and form supercoils in daughter DNA and also separate the daughter DNA after replication, prevent replication and separate the strands after replication. So they are bactericidal. Okay, so they inhibit DNA gyrase and all this happens. So what is the antibacterial spectrum? So ciprofloxacin is a prototypic drug. It is effective against E. coli, Proteus, and Salmonella, and Shigella, okay, then Campylobacter, Vibrio cholerae, etc. Okay, it has activity against Staph aureus also, tuberculosis also. So pharmacokinetics, it is administered by oral, IV, or topical routes. Okay, it is excreted mainly in the urine, widely distributed in the body. What are the adverse effects? Widely distributed. So GI, nausea, vomiting, CNS, headache, dizziness, hypersensitivity, just like sulfur drugs, skin rashes, urticaria, itching. And then see, queen, right? Queen is a QT. So QT interval, and also T for tendon, tenosynovitis and tendon rupture in athletes. In drug interactions, so ciprofloxacin should not be given with warfarin because it potentiates its action and increases warfarin concentration, inhibits its metabolism. And also antacids and ferrous salts and sucralfate reduce the absorption of ciprofloxacin. Okay. So basically, moving on to the classification. So first generation, you have norcipro, so norfloxacin and ciprofloxacin, oral or topical, and IV. Okay. So norfloxacin, remember, it is mainly against gram-negative organisms, but not Pseudomonas. Just write this point. Ciprofloxacin, all the points, organisms. Okay. And levofloxacin, it is effective in typhoid, bronchitis, community-acquired pneumonia, skin, soft tissue, and urinary tract infections. Gemifloxacin, community-acquired pneumonia and bronchitis. Okay, just write 2 of these. Write names of organisms it is effective against if you don't remember anything. Uses of fluoroquinolones. See, first remember, fluoro means a flower. So draw this. It looks like prostate. So it is used in prostatitis. Next, if flowers are beautiful, right? So beauty is usually because of skin in people. So skin infections and soft tissue infections and bone infections due to Staph aureus, you can use them. If someone is beautiful, more chance of STDs, right? So sexually transmitted diseases such as chancroid, chlamydia, and gonococcal infections due to gonorrhea. Okay, next, again, prostate means it is affecting the genitourinary tract. Genito we discussed, urinary and excretory, so UTI and diarrhea, you can use it. Okay, and also andarki flower system. So andarki is anthrax. Okay. So penicillin was the first antibiotic developed and used clinically. It was discovered accidentally by Alexander Fleming. Now the source of penicillin is Penicillium chrysogenum. Okay. So mechanism of action, beta-lactam antibiotics. So what are beta-lactam antibiotics? They have a beta-lactam ring in their chemical structure. They include penicillin, cephalosporins, carbapenems, and monobactams. Okay, so beta-lactam antibiotics produce bactericidal effect by inhibiting cell wall synthesis in susceptible bacteria. So bacterial cell wall has cross units of NAM, N-acetyl muramic acid, and NAG, N-acetyl and glucosamine. So NAM and NAG are cross-linked by pentaglycine bridges. Okay, the NAM has A, G, L, A. Okay, so what does transpeptidase enzyme do is it removes the last alanine and causes cross-linking of the cell wall components to each other with the pentaglycine bridge, glycine moiety. Okay, this cross-linking helps maintain the strength of the cell wall. It makes the cell wall rigid and stable. But when beta-lactams are used, what they do is they inhibit this transpeptidase enzyme, so cross-linking of the cell wall cannot occur, and these cell wall deficient forms are produced which undergo lysis, so bactericidal action. So beta-lactams exert their cidal effect when the bacteria are actively multiplying and synthesizing the cell wall. So the cell wall in gram-positive bacteria is 50 to 100 layers thick of peptidoglycan, which is highly cross-linked. So easily this transpeptidase enzyme can be inhibited and penicillins can act. Whereas in gram-negative bacteria, the peptidoglycan layer is very thin, but it has a thick lipopolysaccharide layer on top. So the penicillins and other drugs, they cannot penetrate that. So they're not very effective in gram-negative bacteria. So what is the mechanism of bacterial resistance to penicillins? When studying Staph aureus, you studied PBP, protein-binding peptide. So altered PBP2A, which have less affinity, and also they produce beta-lactamases, which destroy the beta-lactam ring as in Staph aureus. Okay, and also there could be decreased ability of the drug to penetrate its site of action. So pharmacokinetics, penicillin is acid labile. So if you give it, it is destroyed by HCl in the stomach. Okay, so that is why it is usually given by IV route. Okay, and also it poorly crosses the blood-brain barrier, and but it is widely distributed in the body and is excreted in the urine, mainly by active tubular secretion. Okay, so how do you prolong the action of penicillin? By combining with poorly water-soluble compounds such as procaine and benzathine, which are poor water-soluble, and prolong its action. Okay, so penicillin G. Okay, so you give 20 million units daily. Duration of action is only 4 to 6 hours. Okay, 4 to 6 hours. But procaine penicillin G, it is active till 12 to 24 hours. Okay, and then benzathine, penicillin G, it is active for 3 to 4 weeks. Okay, they are poor water soluble and they are repository penicillins or depot penicillins. Okay, so these are the preparations of penicillin. And adverse reactions, again, skin rashes, urticaria, dermatitis, bronchospasm, and anaphylactic reactions. So anaphylaxis is IgE mediated, an immediate type of hypersensitivity, type 1. So it is not dose related. Even if you give a large dose or a small dose, the drug reaction can occur with any dosage form. Okay, so what is the treatment? Again, injection adrenaline, injection hydrocortisone hemisuccinate, and injection diphenyramine or chloramphenicol. Chlorpheniramine. Next, precautions. Before giving any penicillin, history of previous administration and allergic manifestations must be recorded in patients with history of asthma, allergic rhinitis, or hay fever. There's increased risk of penicillin allergy, and sensitivity testing should be done. Other adverse effects are Jaris-Herxheimer reaction. So in patients, so it is an acute exacerbation of signs and symptoms of syphilis during penicillin therapy because of release of endotoxins from the dead organisms. What are the manifestations? Fever, chills, myalgia, hypotension, circulatory collapse, etc. You give aspirin. So what are the limitations of penicillin G? So it is acid labile, it has a short duration of action, and it is destroyed by penicillinase, and there's a possibility of anaphylaxis. To overcome most of the above drawbacks, we give semi-synthetic penicillins. So semi-synthetic penicillins, they include acid resistant ones such as penicillin V. Okay, acid, reverse it, you get V. Acid resistant, penicillin V, and also penicillinase resistant. So if you put a cloak on penicillin, or if you make it of oak, that's strong, right? So it is penicillinase resistant. So you have these things. And also other ones include extended spectrum ones such as ampicillin and amoxicillin, which can be given oral, IM, and IV, and carboxypenicillin such as carboxypenicillins and piperacillins, okay, uridopenicillins. So these are the semi-synthetic derivatives. So basically this is acid resistant, this is penicillinase resistant, okay, rest all are penicillinase susceptible. Okay, so ampicillin, amoxicillin, you can give it for gram-negative bacilli also. That is why it is extended. Okay, that is what it is saying here. And what are the adverse effects? They are similar to those of penicillin G. Congestive cardiac failure may be precipitated. Okay, just write dermatitis, skin rashes, urticaria, and allergic manifestations, etc. Yeah, hypersensitivity. So what are the therapeutic uses? First, throat means pharynx, and also sinusitis, bronchitis, etc. Everything in the respiratory tract. Next, first you talk about the respiratory tract, then CVS. In rheumatic fever, you use prophylaxis, benzathine, penicillin G. Next, again, respiratory tract over, CVS over. Next, urinary tract. So urinary tract infections. Genito, you have syphilis, you have gonococcal infections, etc. Okay, so syphilis is STD, so Jerisch-Hersheimer reaction also, and also STD, right? So T for typhoid fever, again respiratory, and D for diphtheria. Okay, so you have these things, and urinary tract is over. Now other excretory tract, you have alimentary tract, so bacterial dysentery. And also Helicobacter pylori infection, you use amoxicillin. What are the drug interactions? Probenecid competes with beta-lactams for active tubular secretion and retards their excretion. So what? Just let us look at the comparison between ampicillin and amoxicillin. So ampicillin is acid stable. Both are acid stable and both are semi-synthetic. But remember one thing, it is ample, right? So if it is able to do its work, food will hate it because it is not lazy. It is amply doing its work, so food will hate it because it is not lazy. So food tries to make it lazy and decreases the absorption of ampicillin. And food likes her, okay? So it is effective against Shigella. To protect Shigella, food decreases ampicillin absorption, okay? And ampicillin, it hates her, so it reduces the effectiveness of oral contraceptives, and exact opposites. Amoxicillin, food does not reduce. So amoxicillin, it does not reduce effectiveness of oral contraceptives and less effective against Shigella. Okay, so what are beta-lactamase inhibitors? They are clavulanic acid. Beta-lactamases, they inhibit the action of penicillin, which have beta-lactam rings. So lactamase inhibitors prolong the action of penicillin and other beta-lactam drugs. So they are clavulanic acid, sulbactam, etc. Lactam, replace it with V, you get bactam. So clavulanic acid, it is isolated from Streptomyces clavuligerris. Okay, after binding to the enzyme, it itself gets inactivated. It is a suicide inhibitor. So what are preparations of beta-lactamase inhibitors and their uses? So you have clavulanic acid and amoxicillin, okay, skin and soft tissue, Oxsoft, clear skin, okay, and then sulbactam and ampicillin, oral IMIV, both, and intra-abdominal and pelvic infections. Under, okay, pelvic, abdominal. Cephalosporins, they were first obtained from a fungus Cephalosporium. Later semi-synthetic ones were developed. So they are also beta-lactam antibiotics. So transpeptidase enzyme, they block it, and that is how they work. The mechanism of action is similar to that of penicillin. They prevent cross-linking of the cell wall components and cause lysis of the forms. They are bactericidal. Okay. So cephalosporins are they are basically beta-lactam antibiotics with 7 amino cephalosporanic acid nucleus. 7 amino cephalosporanic acid nucleus. Okay, so basically you have 5 generations of cephalosporins. So remember this trick. Okay, write cepha. Okay, so Zollinger, okay, Zolin, okay, Zollinger Fox says fix me, pimi, okay, Zollinger Fox says fix me, pimi. So cepha, Zolin, cefoxitin, foxtin, okay, cefixime, and cefepime, okay. So they are first, second, third, and fourth generation drugs. So basically, gram positivity decreases, gram negativity increases. Okay, they are not penicillins. Okay, they are opposite. So gram positivity decreases, gram negativity increases throughout the generations. And also at the same time, beta-lactamase, they are susceptible, the older generation drugs, first generation ones, and then rest all are resistant to beta-lactamases produced by gram-negative bacteria because they are more effective against gram-negative bacteria. Okay, and these third and fourth generation drugs are effective against Pseudomonas and Salmonella. Okay, and also blood-brain barrier also, they can the crossing ability increases throughout. So first generation, you use it in skin and soft tissue. Okay, first think of the face, skin. Next, nose, respiratory tract infections, second generation drugs. Third generation, all the tracts, sexual transmitted diseases, urinary tract infections, diarrhea, pneumonia, etc. And then fourth generation drugs, you use it in hospital acquired infections. Okay, so those are the uses. Fifth generation cephalosporins, they all are prodrugs. Okay, ceftaroline, okay, ceftaroline, and they are effective against gram-positive and gram-negative bacteria both, including methicillin-resistant Staph aureus and penicillin-resistant organisms. Pharmacokinetics, they are given orally. They have metabolism in the liver. Okay, they are excreted in the urine. Some are metabolized in the liver. Okay. Then that is what it is. And adverse effects, again, you have hypersensitivity, GI disturbances, mainly diarrhea, vomiting, and anorexia. Hypersensitivity, you have skin rashes, urticaria, and rarely anaphylaxis, pain at the site of IM reaction, IM injection. Okay, so this is all about cephalosporins. Carbapenems, examples are imipenem, imimerador, so imipenem, meropenem, and doripenem. Okay, so imipenem is a semisynthetic beta-lactam antibiotic. Like other beta-lactam antibiotics, it acts by inhibiting bacterial cell wall synthesis, produces bactericidal activity, and it has a wide spectrum of activity. So name some organisms which you can remember: gram-positive like streptococci, staphylococci, gram-negative enterococci, and anaerobic organisms as well. Okay, so basically, you give it by IV route. So pen, right? Pen pierce the vein, so IV. So intravenous imipenem, glomerular filtration in renal tubules. Then you have dihydropeptidase, hydro in renal tubules in urine. You have dehydropeptidase. Okay. So it causes hydrolysis of imipenem and it is excreted in the urine. So what do? You give a dihydropeptidase inhibitor, so cilastatin. It increases the concentration of imipenem and it increases the efficacy. Okay, it may exhibit cross-reactivity with penicillins and cephalosporins. What are the common side effects? So skin rashes, nausea, vomiting, other things. Okay, other carbapenems include meropenem and doripenem, merador. Okay, so it again IV and not destroyed by dihydropeptidase. Okay, so this is all about carbapenems. They are used in hospital-acquired infections. They are resistant to beta-lactamases. Okay, that's it. And finally, uses hospital-acquired infections. Just write some microbiology unit names and that you should be fine. And again, monobactam, they only have one monolactam ring, one ring in its structure, so monobactam. It also acts by inhibiting bacterial cell wall synthesis. It is mainly again effective against gram-negative, negative only bacteria. Example is Astreonum, Astex, okay, Astreonum, okay. Next, it has no activity against gram-positive bacteria and anaerobes. Okay, so there is lack of cross-reactivity, administered only parenterally, and it is resistant to beta-lactamase enzymes, again used in hospital-acquired gram-negative infections.